So today's study tip is to use more than one textbook. Comparison reading will give you perspective and will help you catch errors in your understanding. So many of our students like to keep this textbook and other textbooks they get in their anatomy, microbiology, other physiology courses. It can help them study for nursing school and beyond. Now we're into chapter 16, the respiratory system. This is the first of 2 videos on the respiratory system. And as always, we start with terminology. So respiration is the process of obtaining oxygen and eliminating carbon dioxide. External respiration is the exchange of gases between the alveolus and the blood, while internal respiration is the exchange of gases between the tissues and the blood. So you can think of it in this way. We need to get oxygen into our initial tissues, into our blood from the outside environment, from the alveolus, and then get it from the blood into tissues. Because our tissues are going to be the ones that are going to be using that oxygen to power cell respiration and then produce carbon dioxide as a waste product. Finally, ventilation is breathing. So people often say respiration when they really mean ventilation. Because again, respiration is this process of obtaining oxygen and eliminating carbon dioxide, while ventilation is breathing. So that's how we're going to talk about it in this class. So I'll remind you of the anatomy of the alveolus. You have a fluid with a surfactant in it on the borders of your cells here too. So here's a type 1 alveolar cell with inside there's fluid with surfactant on it that helps the lungs grow and stretch as you intake air and expel air. We also have type 2 alveolar cells, alveolar macrophages, and then of course interior tissues. In those capillaries we have the red blood cells, and white blood cells are going to be either in the capillaries or infiltrating tissue around here too. Okay. So our alveoli are the site of gas exchange. The type 1 cells are flat and single layer. The type 2 cells are the ones that secrete the surfactant. And surfactant is composed of lipids. It decreases alveolar surface tension. And it's given to neonates that have newborn respiratory distress syndrome. So particularly premature infants have a problem with the type 2 cells and secreting enough surfactant in order to breathe properly. So you can actually give these cells and give surfactant to neonates in order to improve their breathing. So this is really important for moisture of the alveolus and adequate stretch, so you can adequately transfer oxygen from the air into tissues. So let's remember some of your anatomy. We have a conducting zone and a respiratory zone for the respiration system. Okay, so our conducting zone consists of the trachea coming down here from the throat. That divides into primary bronchi, and eventually that divides into a bronchial tree, and it looks like a tree, right? With terminal bronchioles and alveoli at the end. So about alveolar sacs are about 8 million per lung. Okay. And the alveoli, we said, were the actual respiratory zones. Here's where you can actually transfer oxygen and carbon dioxide is in the alveoli, or in the alveolus, right? Singular. So it's alveolar sacs, like bunches of grapes all around here at the end of these terminal bronchioles. Looking into this pleural sac around the lungs, I wanted to show you this view of it. And so if we're looking at it from the sort of top, somebody's cross-section, here's the sternum at the front. Here's the spine at the back, right? So here's a thoracic vertebrae. That's how you can tell that we're in the thoracic or chest area. And then from the top, then we see lungs on both sides. So we see lungs filling the space on both sides with the heart in the middle. And particularly this pleural sac around the lungs. So see this parietal pericardium around here. And then a visceral pleura and a pleural cavity that's this nice little space here surrounding it. Okay, so that's what I wanted you to notice here in this picture. So it divides then your chest into a pericardial cavity and a pleural cavity. And this becomes important later on. And you see these tubes for the esophagus then coming down parallel to that trachea. So now we got to talk about pressure, because this idea of respiration is all based on atmospheric and intrapleural pressure. So we can measure pressure in millimeters of mercury. So mmHg is going to be our measurement of pressure. Okay. And this is what it would look like if a barometer was used to measure atmospheric pressure. And remember that gases are going to move from high to low pressure. I like to think of it as similar to any kind of solute that's moving from high to low pressure or high to low solute level. Gases are going to move from high to low pressure. Okay, so we got to think about 3 pressures when we're thinking about how breathing works. One is going to be the atmospheric pressure, designated as ATM pressure. And this is going to be at 760 millimeters of mercury. This is due to the weight of air, which does change with weather. So when we look at barometer, it's going to change a little bit based on the weather. It also changes based on altitude. So we see decreased atmospheric pressure when you have an increase in altitude. So Tahoe, for example, has a lower pressure than San Jose. The second one we have to consider is the interpulmonary pressure found in the alveoli. And this is going to fluctuate, but it fluctuates around atmospheric pressure, so around 760. If it's lower than 760, air flows into the lungs. If it's higher than 760, air flows out of the lungs. And changing this is how we determine where air flows, into or out of the lungs. The third one is the intrapleural pressure in the pleural sac. And this is typically 3 to 6 millimeters of mercury less than atmospheric pressure. And so it's considered to be a negative pressure. It produces what's called a transmural pressure gradient across the wall that help keep our lungs close to that thoracic wall. So it keeps our lung inflated. And so if somebody has pneumothorax, a hole in the chest, the transmural pressure becomes 0 and then the lung collapses. So when you see about collapsed lung, particularly that can happen from pneumothorax, and so we get that due to this change in pressure and loss of pressure in that pleural cavity. Okay, so looking at this in terms of the different pressures, we can look at rest versus an inspiration. So here we are at rest. Note the diaphragm here is nice and close to those lungs. Atmospheric pressure is the same. And look here is that at rest, atmospheric pressure matches intrapulmonary pressure. At inspiration, take a breath in, you have a change in intrapulmonary pressure. Look at the change happening here. The diaphragm pulls down, creating a lower pressure in the intrapulmonary pressure. So 757 is lower than 760, so air is going to come into the lungs. When you go to breathe out, that diaphragm relaxes and comes back up towards the lungs. That creates a higher intrapulmonary pressure than atmospheric pressure, and so air moves out. So it's not that you're sucking in air or pushing air out when you breathe. It's that you're changing pressure in this chest cavity, your intrapulmonary pressure, that either, and that's due to movement of the diaphragm mostly, that will either cause air to move in for inspiration or cause air to move out for expiration. Okay, so I mentioned pneumothorax, where you have a hole, chest wound, for example, that breaks this space here, and so you have a loss in that pleural pressure, and that then causes this collapsed lung, causes that lung to pull away from the wall. So we know that that pressure is crucial to maintain lung space and size here. And you can imagine that when the lung is collapsed, it can't transfer oxygen as effectively, and so we quickly see problems with people breathing and eventually oxygenation of tissues. Okay. So for the mechanics of breathing, we have to consider something called Boyle's law of pressure, which is 1 over volume. And so if you have an increase in volume, then you have a decrease in pressure. So like I said, on your inspiration, on your inhale, the diaphragm and the external intercostal muscles contract. That causes thoracic volume to increase and the lungs expand. And as the lung volume increases, therefore, the intrapulmonary pressure decreases, such that it's below the atmospheric pressure, and so air flows passively from high to low. So again, you're not sucking in air. The active part of this is contracting these muscles that then allow the lungs to expand and allow intrapulmonary pressure to decrease, so air flows into your lungs. On an expiration, an exhale, it's a passive action, so you're relaxing your muscles. Thoracic volume decreases. As lung volume decreases, the intrapulmonary pressure increases, and now it's higher than atmospheric pressure. So air passively flows from high pressure in your lungs to low pressure outside. Okay, remember we got to think back to flow. Don't forget about flow. Flow is pressure over resistance. And so we think about this in the same way we thought about blood flow or pressure in the kidney, right? Resistance changes with airway radius, just like in blood vessels. So the parasympathetic nervous system stimulates bronchoconstriction, while the sympathetic nervous system and epinephrine stimulate bronchodilation. So you can imagine then when somebody's having constriction of the lungs, you can stimulate bronchodilation with epinephrine so they can increase breathing. So you think about asthma attacks and other ways in which to improve breathing. So respiratory disorders like asthma, chronic bronchitis, cystic fibrosis, and emphysema can affect these things like resistance and stimulation. And acute symptoms like acute asthma can be treated with epinephrine if it's really, really crucial, right? So this is even true of an allergic reaction where you have inflammation. You can inject epinephrine to stimulate bronchodilation so that somebody can breathe. Okay. So what's happening in asthma is that there's a constriction of the airways. So in a normal airway, we see this nice open space here. We see relaxed, smooth muscles. In an asthmatic airway, the wall is inflamed and thickened. During asthma attack, in addition to this being a smaller space, the smooth muscles around the bronchioles are tightened. And so that space then is very, very, very small. So not a whole lot of air can then get into this person's lungs. Notice that the air is then trapped in the alveoli and it can't move, so it can't exchange oxygen and carbon dioxide like it needs to do. In bronchitis, we see excess inflammation and mucus as well. And particularly for something like cystic fibrosis, we see that there's going to be thick, sticky mucus in the airway then too. So when anything is blocking this, either mucus or it's constricting this pathway, now we have less opportunity for oxygen to flow. The thick, sticky mucus associated with cystic fibrosis can also lead to bacterial infection. And so the only real treatment for cystic fibrosis has been for people to expel this mucus continually so that they can then transfer oxygen and so they don't get a bacterial infection. So excess mucus and blockaging of this bronchiole is really dangerous. Okay. Next, we're going to talk about emphysema, which also causes mucus in the bronchiole. And it also allows and causes enlarged alveoli, which the problem with this is that with enlarged alveoli, you have fewer capillaries. You have less possibility of oxygen and carbon dioxide exchange at the alveolus. So essentially emphysema, mostly due to smoking, is going to be damaged alveoli, and you get then reduced surface area, and so therefore poor gas exchange. So this, lots of small alveoli with lots of capillaries surrounding them, that surface area is critically important for transfer of oxygen and carbon dioxide. And so damaging of the alveoli and poor gas exchange is again very dangerous for oxygenation. Okay, let's think about a case study here. Mr. Ellenheimer, a 68-year-old heavy smoker, took the charter bus to Reno to gamble. Going over the Donner Pass, Mr. Ellenheimer experiences slight difficulty breathing between coughing up phlegm. He ignores it because it happened several times in the past. He's happy playing cards with his friends, Edna and Marge. So once Mr. Ellenheimer arrives at the casino, he feels better, so he races to his favorite machine. He lights up a cigarette and begins to have increased difficulty breathing. So I want you to think about and name what external and internal factors could be affecting his breathing. And as usual, if you want to check your answers with this, come see me in office hours or talk to me in lab. Okay, so I want to show you this graph here, and note that I want you to memorize all these terms and their values. Okay, so I want you to know what's happening here. This is called a spirogram. It's showing lung volume here on the y-axis in cubic centimeters. And this gives you capacities, okay? So tidal volume is the space here, the small space here, what's happening as you normally inhale and exhale. So as you inhale, your lung volume increases. You exhale, your lung volume decreases. That's tidal volume, okay? And that's somewhere around 500 cc's. If you take a normal breath in, though, and then you breathe in as much as you possibly can, that total is called your inspiratory capacity. The inspiratory reserve volume, IRV, is the difference between inspiratory capacity and your tidal volume. So if you're normally breathing here, that extra you can breathe in if you try really hard is going to be that reserve volume. Just as you're breathing in, breathing out, if you breathe out normally, you'll be down here. If you then blow more air out, you get your expiratory reserve volume. And note that there's always a residual volume in your lungs. So this residual volume, about 1,100 cc's, you cannot breathe all the air out. So if you breathe all the way out, there's still some air left in your lungs. There has to be, okay? And so vital capacity is IRV, or inspiratory capacity plus expiratory reserve volume. Or you can think of vital capacity as IRV plus ERV plus tidal volume. But it's the total possible amount you can exhale from your lungs. Functional residual capacity is the combination of expiratory reserve volume and residual volume. And total lung capacity is the total amount of air you can fit in your lungs. Okay. So again, memorize all these terms and memorize their values. Okay. Here's the terms, the definitions. More for you to remember. And now for some not fun facts. So this has become even more not fun as we started thinking about COVID over the last few years. A cough releases an explosive charge of air that moves at speeds up to 60 miles per hour. A sneeze can exceed the speed of 100 miles per hour. So whenever you sneeze or cough, please keep your mask on, or cough or sneeze into your elbow or armpit. So now we have lots of graphs like this. And again, this is looking at something like Ebola and measles. And this is part of what makes some of these diseases so infectious, right? Ebola's particles are much larger. And so while they are expired in coughs and sneezes, they don't go as far. Measles can stay as tiny particles in the air for hours and hang out there in the air and go much further. Very soon, we're going to start seeing COVID graphs like this, right? So we now know that infectious droplet nuclei from things like measles and COVID can travel very far. So of course, social distancing has proved to be somewhat important with COVID, but what we know is that that 6-foot guideline is just a guideline, and it does not prevent you from getting COVID. So other measures like vaccines and masking are very, very important. Okay. So some notes here on ventilation. When you talk about calculating pulmonary ventilation in milliliters per minute, so how much you're actually breathing, you're going to take the tidal volume in milliliters per breath and multiply it times the respiratory rate. So just like you can think of it similarly to cardiac output, right, where you had stroke volume times heart rate. Now we have tidal volume times respiratory rate. And if respiratory rate equals 12 breaths per minute and tidal volume equals 500, then you multiply them to get ventilation of 6,000 milliliters per minute, or 6 liters per minute. To increase ventilation, typically someone's going to increase tidal volume or respiratory rate, but usually you do it both together. So usually if this is going to be increased ventilation, both these things are happening in your body. So actually a more accurate measurement then of this is going to be alveolar ventilation, because this considers that 150 milliliters of the 500 milliliters of tidal volume is actually dead space, right? Because remember, you have all that space where you're not actually conducting oxygen and carbon dioxide. So alveolar ventilation, a more accurate measurement of ventilation, is going to be tidal volume minus dead space times respiratory rate. So if we have 4.2 liters per minute of alveolar vent, we get a less than 6 liters per minute of pulmonary ventilation. Okay, and that's it for today. I'll see you next time for part 2 of respiration.